We've been doing a number of checkpoint inhibitor-based combinations for AML and MDS now for the last 4 to 5 years. The ones that have been showing the best activity of the many different trials we've been doing are the combinations of hypomethylating agents. Specifically, azacitidine is the one that we use in our trials in combination with PD-1 inhibitor, nivolumab or pembrolizumab. And one of our trials that we published recently in Cancer Discovery was a combination of azacitidine, nivolumab in relapsed acute myeloid leukemia. What we saw was in a population that was median of 2 salvages, and about half of these people had secondary AML and adverse cytogenetics, so a relatively high-risk population, but is kind of the population we often see at MD Anderson in the relapse setting. The overall response rate was about 33%, and we compared this to a propensity-matched group of control with other azacitidine single-agent or decitabine single-agent based treatments, and we saw that the response rate there was about 15%. So the response rate seemed to be about double of what you would get with aza or decitabine alone. But what was really interesting was the survival, especially in the early salvage 1 and 2 population, was about 11 months. And this is actually the survival we get with azacitidine, decitabine in the frontline setting. So it was quite encouraging to see the salvage survival equaling what we see in the frontline setting. And we think this was because of the addition of the PD-1 inhibitor. The other thing is we did a lot of immune correlative work with our immunotherapy platform. We have the fortune of working with Pam Sharma, Jim Allison, some of the world experts in immunotherapy, and we were doing flow cytometry as well as mass cytometry, RNA sequencing, and cytokine profiling. And we actually see that there's a very clear correlation between a number of immune correlatives and prediction of response. So basically people who had more T cells in their bone marrow, either as absolute numbers or a proportion, were the ones who had a much higher response rate. The response rate in that group was about 56% compared to 25%. And then when we did cytokine profiling using a single cell cytokine analysis that's being developed in the United States with us and a company called Isoplexis, we saw that we were actually able to predict almost 100% among the batch of responders, non-responders that we sent to them. So basically, just like mutational complexity and mutational heterogeneity, there's immune heterogeneity in acute myeloid leukemia. It's not a homogeneous system. We wouldn't have expected it to be, but we still have to show that with data. So there are some people who are very immune activated, and these are the people who respond well to checkpoint, also to bispecific antibodies. Some of that data was shown by Dr. Dipurusho Ravandi at ASH. And then there are some which we call the immune desert or immune depleted patients. And in those people, these regimens aren't going to work because they don't have T cells, or even if they have a few T cells, they're not producing cytokines and they're hypofunctional. So I think the next step now, there are actually a number of studies ongoing, about 25, 30 different studies in the US. Some of these are smaller studies, some of these are phase 2, is to do biomarker-driven studies. I think it's just like if you use an IDH inhibitor in all patients, you would see minimum or low response. But if you use an IDH targeted, you see a much higher response. So I think the same way we need to select these people either by using T-cell profiling, by flow cytometry, immunohistochemistry, or by cytokine production. And so we are now working on developing a couple of these studies, which will hopefully be done in 8 or 10 centers. I think one of the very important things to highlight is the toxicity profile with these agents. So we do see immune-related adverse events. The incidence with the azacitidine nivolumab that we published is about 20-25%. This initially we thought was lower than what was seen in solid tumor. But with the recent solid tumor data coming out with renal cancer, lung cancer, it seems that in the clinic, in the common use, the incidence of these immune toxicities is about 20% or so. But the organs that are involved are a little bit different in leukemia. We get much more pneumonitis, we see some colitis, nephritis, transaminitis, but in the solid tumors, they see much more endocrine, skin, and liver issues. So there's a difference in the profile. The good thing is, at least in our experience now, we've treated almost 250 people on different immune checkpoint combinations. They respond very quickly and dramatically to steroids. But the timing of starting steroids is very important. If the steroids are delayed, then these immune toxicities may become irreversible or severe. But if they're started early, almost 95% respond rapidly and quickly. So we're actually now publishing some of our guidelines in a couple of reviews that are upcoming on how to manage these immune toxicities, because we've heard from other centers who have not used these drugs as much that they are seeing more toxicities, and these are becoming severe because of lack of awareness, lack of steroid activation, and other things. So I think this will be quite important for both immune checkpoints, bispecific antibodies, CAR T cells, the whole immunotherapy field, management of toxicities. Yeah.